Welcome to Quality, where we're exploring quality in emergency care. This is your host, Arjun Venkatesh, and today's episode is the next in our series as part of the Emergency Quality Network Substance Use Disorder Initiative. I've got two special guests today, totally new topic. Joining us are Dr. Deepa Camenga, who is a pediatric addiction medicine specialist at Yale and a lead of a new project within E-QUAL that is focused on treating opioid use disorder for kids and adolescents across pediatric EDs. And I'm also joined by Dr. Chris Buresh, who is a very unique guest. I think the first person on this show, and maybe even the first person I've ever met, who is both board certified in emergency medicine as well as in pediatrics, and is currently at the University of Washington out in Seattle. Thank you guys both for joining me today.
Thank you for having us.
Yeah. So I got to say, today's episode's a little bit different than what we're used to, because when I say the word opioid use disorder, and we're usually talking to emergency physicians or clinicians around this country, the first picture I'm sure everybody gets in their head is of an adult. And then when I say pediatric opioid use disorder, people are probably first thinking about, you mean like an accidental ingestion or a kid who gets their hands on their parents' pills at home, not actual opioid use disorder. But you have both come to teach me that that is not exactly the case. And so tell me about how you came into your current roles as champions for treating OUD in kids and adolescents.
So I guess I'll start. I'm a pediatrician. I'm board certified in addiction medicine. For about 15 years, I've been treating teens and young adults, and very early on noticed how prevalent early substance use and substance use disorders were. I was lucky early in my career to have mentors who helped me understand what addiction medicine was, and started incorporating it into my practice. And through the years, have really dug into this work. I've started programs in a variety of settings to help teens. One of the settings is in the hospital setting, a consult service. And through that consult service, we do see teens in the ED with opioid use disorder. And I also, I'm very familiar with outpatient, the importance of linking to treatment in the outpatient setting as well. So it's really because I just love taking care of teens, and I find the work to be extremely fulfilling addiction medicine.
Yeah, that's great. I had a different path. So I started at the University of Iowa and spent the first 15 years of my career there or so, and was really interested in vulnerable populations. And so I was approached by the Iowa Harm Reduction Coalition to help with some of the early naloxone distribution efforts there. And I think that was kind of during the third wave of the opioid crisis, and not too long after some of the publications from Yale had come out about treating people in the emergency department with buprenorphine. And so we started trying to do, we did a lot of statewide advocacy to get naloxone to be available more widely. And then started, trying to treat people in the emergency department with buprenorphine. And then I moved out to Seattle in 2020. Where things were just a lot more sort of set up to do that. And I started working at our county hospital at Harborview Medical Center, where people had already started really putting together programs to treat opioid use disorder in the emergency department. And, take-home naloxone was a thing already, and they had started doing a lot more buprenorphine. And so then when I started at Seattle Children's, there, in late 2020, I said, what are we doing to treat opioid use disorder in kids? And the attitude was kind of like, well, that's an adult problem. That's not really a thing. And I think on my second shift, I saw a kid that was in horrible withdrawal. And so, just using that experience, we really started to build a program to treat this, because we, at the time, we didn't have buprenorphine anywhere, even in the hospital. It wasn't on the inpatient formulary, the outpatient formulary. And so really had to do some work and really had some great allies. I have to tip my hat to the folks at Children's who really leaned into this to make it possible. And from getting buprenorphine in the hospital to stocking naloxone in the Pyxis and all these other things, all this education that had to happen. And really, I think the first kid that I saw was, really struggling and was homeless and dropped out of school. And, a year later, he had he'd been on his meds. He got back into school. He graduated on time and now is in community college, and he's studying to be a substance use counselor.
Oh, that's an
And
awesome story. I
yeah,
mean, right? That's why, like, I think that's why we want to have you guys on, because you have this, it's sort of like the horizon opportunity in pediatrics, where if you have the opportunity to change something like opioid use disorder and treat it in a kid, there's so many future years and a future life that's wildly changed from that. You mentioned the words, Chris, protocol and programs, and that's sort of the bread and butter of E-QUAL, right? We do quality improvement. We try to take standard quality improvement methods and bring them to big problems in emergency care. And right now we're doing a lot of that around opioid use disorder and alcohol use disorder. What does that protocol look like for you guys? Is it, very complicated? Is it very different when you're taking care of adults versus kids? But what's sort of that pediatric buprenorphine protocol for OUD look like?
Yeah, it looks very similar to the protocol that we have at Harborview at the county hospital. We started doing something a little bit different where we screen based on chief complaint, because we really hope that our residents are doing like a heads screening exam on every adolescent that comes through the ED, but I think we all recognize that that doesn't happen all that often. And so when kids come in, when adolescents come in with one of 12, 13 chief complaints now that we think might indicate a higher risk for opioid use disorder, best practices alert fires, and that really triggers everybody to say, hey, for sure in this case, I need to do like a head screening and ask a little bit more about substance use. And so, the protocol then is that we have a discussion. If we think the kid is at risk for substance use disorder or harm from an opioid, we offer them discharge naloxone. And then if we think that they really have an opioid use disorder, we have a discussion with them, and if they're willing, with their parents, about the use of buprenorphine. And we've increased our dispensing of naloxone by something like 400%, and buprenorphine by something similar with the screening. I think we were just seeing a lot of it before, but we weren't recognizing it, and this has really helped open our eyes.
Yeah, you're right. That approach does sound really similar to what we have put together in sort of the ACEP pathways for treating OUD in adults. And I learned as a third-year medical student that you're not supposed to call kids little adults when you're talking about treatment. But Deepa, tell me, what are the medical aspects for managing OUD that are unique in children?
I think actually some aspects are quite straightforward. We don't have usually the high level of comorbidity um, that adults may have. It's pretty straightforward. The teens tend to tolerate it really well. We also use we could talk about this for hours, but in my clinical experience, the doses, it's pretty standard dosing. It's nothing special. We don't have to do much fancy with the doses. Um, and I think most of it is really straightforward. And I also see adults in the inpatient consult service. I mean, it's way more straightforward. Where the art is in just identifying it, number one, because teens don't seek care for OUD or even withdrawal. It's coming in secondary a lot of times. And that's because of stigma and other things, and also parents being involved is unique. Those are the two aspects that I find most unique in caring for teens. But the medical management is pretty similar and straightforward.
I want to go back to dosing, but before we go there, I got to say what you were saying, that I almost felt nervous just talking to you guys in a podcast, thinking about the idea of walking into a room with a teen who I've never seen before, who's come to the ED, like you said, was probably not saying, I'm feeling like I'm in opioid withdrawal, another chief complaint, recognizing that that they might have opioid use disorder, and that mom or dad is like sitting in a chair on the other side of that, hallway or ED room, whatever it is. And I'm trembling about just the idea of raising the subject. And so how does that go? How does that feel? What does that conversation usually look like?
Yeah, I mean, I can start. I think it is tricky, and it's I think, it can be a little bit nerve-wracking, but I think at the end of the day, everybody wants the same thing in that room, right? Everybody, the kid wants to not be sick. The parents want their child to not be, have an opioid use disorder, be dependent on opioids, and they really want them not to die. And I think that kind of, I have a shared decision-making discussion with everybody about, the adult literature, which shows a 5% 1 year mortality after a non-fatal overdose. And I say to them, look, there's not another kid in this emergency department. If that applies to kids, there's not another kid in this whole emergency department that has that kind of 1 year mortality right now. You are the sickest child in our department. And I still don't think that lands all that well with teenagers who are bulletproof and immortal, but it does with parents. And so I think, for the kids, I'm like, hey, look, you don't want to go through withdrawal. You don't want to have these cravings. You don't want to have this sort of run your life. We can give you your life back if you take these medicines. And with parents, I really lean into hey, this is a medicine just like any other, and it will keep your child from dying from this disease. And it usually goes pretty well. I think that the big questions in my setting that kids always have is like, do I have to be on this for very long, or can I just take it for like 4 days and then stop, like like an antibiotic? And then the parents are very concerned about the idea of substituting sort of one drug for another, or one drug problem for another. And so we have to really frame it as, hey, this is an illness, just like I've got high blood pressure, and just like I have to take medicine every day for my high blood pressure, you've got to take medicine every day for this for a while, right? And maybe not for forever, but for a while, just to get through the withdrawal. And it takes a long time for those cravings to go away. Um, but but you can do this. And I think when it comes to questions of dosing, we really work hard to dose it sort of on a 2 times a day basis, just like we would for, in pediatrics for like stimulant medications, right? So that they're not having to take them to school where there's a bigger risk of diversion. We try and keep it a twice-a-day thing. But yeah, I think
is there like a go-to first dose when you're seeing a teen or adolescent? I ask because we had a big debate recently. We've got coming out very soon a new adult E-QUAL ASAP protocol around treating OUD, and the way we sort of approached this was reflecting that the prior protocol that had been developed about 4 years ago and posted had a starting dose of 4 milligrams.
Right.
And there's this obvious broad recognition of higher doses are increasingly necessary, whether that's because of the potency of fentanyl, whether that's because of increasing comfort with dosing and prescribing, and a variety of other things. And the way we left it is to actually sort of call it 8 to 16, recognizing that some people are just going to start at 16. Others are going to kind of give 8, but quickly reassess that patient. And if they're still in withdrawal, 8 more. Is there sort of a simple way to do this with the teenager?
I mean, what we've been doing, for better or for worse, is to do 4 and then another 4 right away, after a cow score. And what we found is that about half the kids are doing really well on 4 and half the kids are needing 8. So far, we looked at the first 25 or so of them. And so that seems like it's somewhere in there. I've had one kid that felt like 4 was too much, but she was using all kinds of different things, including opioids. And so she's on 2, but I haven't had too many kids need to go above 8 twice a day.
And can you sort of assess it qualitatively? Like, can a teenager tell you, like, after that first dose, like, I still don't feel well, or now I'm feeling well, and to guide that second dose? Or do you really have to like calculate a cow score to drive all this?
I think you can just have a conversation with. I think it's better to calculate a cow score, to be honest with you, because people, especially in pediatric emergency departments, aren't as familiar with how to assess withdrawal, right? And separating out sort of withdrawal from anxiety or something else that's going on is tricky, I think. And so I do think it's helpful to do another cow score, say half an hour after that first dose, for places that don't treat a lot of withdrawal. But I think for people who are very familiar with the withdrawal, I think, just having a conversation with the kid and saying, hey, do you feel better? Do you feel like you need another dose? After half an hour is probably sufficient.
When you say that, it reminds me of when I was a resident and doing some rotations of Boston Children's. I still remember one of the attendings telling me that, one of the things that was unique about pediatric emergency medicine, he said, was that we have more scores than any other specialty in medicine. And so I think in that way, at least, there's probably broad and rapid acceptance in that setting.
Totally. And I think it makes everybody feel more comfortable too when they have a number, right? If you're in a setting where you don't do this very often, having a number to tell you what to do that you can document in the chart just feels more comfortable, right? I think it's like a warm hug.
Yeah. Deepa, you mentioned stigma, and I think I want to go back to that a little because part of when I think about talking to a teenager or their parents about this is, and we've done podcasts on this before actually, it's talked about how stigmatizing language itself not only influences your ability to identify somebody with an opioid use disorder, but it's going to influence their acceptance of treatment and their engagement in treatment and all this other stuff. And I have like this, like, I don't want to call it a nightmare, but in this image in my head of like having this teenager in the ED and trying to raise the topic and a parent looking at me and saying, "Are you calling my kid a drug addict?" Right. And so how do you disarm that?
I think this is the art of medicine again. I have never had that particularly happen. And if it does, it's most likely because of events that happened before they came into your ED, right? Most parents are concerned, and perhaps the language has to be gentle. You have to lead them to the word opioid use disorder. I try and with parents kind of normalize it. This is not, we're in an opioid epidemic. Teens do have this. We do see this. There are treatments available. Um, and I guess one difference when working with parents is you do have to explain why you're making that diagnosis. They will ask, what is the evidence for that diagnosis, especially if it's a very first diagnosis. And so, Chris might have a different approach. In my sense, I'm very concrete about it. We have a criteria that we use called the DSM. There's 11 signs, symptoms. Your daughter is telling me about that they have 7 of them, and this is why we're concerned. And so you might have to kind of break it down as to why you're making that diagnosis and show the parents. But I haven't, if you explain it to them and that you're using criteria, physical exam, whatever it is you're using, very just matter of fact, they tend to understand.
Do you think that when you're sort of having these conversations that, like, in general, are parents and teenagers sort of, more open to treatment in that emergency department setting? What we've seen in the adult world is we've said, okay, often it's in the setting of somebody's had an overdose, or there's some some event around their opioid use disorder that resulted in an ED visit, and that has often feels like that's created a window for treatment acceptance. Is the same true in that teenager population?
I think so. I think that usually when they're coming into the emergency department, they're there for something that is at least tangentially related to their opioid use disorder, and they're often kind of willing to have a conversation about it. And usually, I mean, honestly, there's often other things going on, right? Like sometimes there's a mental health crisis or something else, and the conversation I have is, hey, look, like I know this isn't why you're here. You're here for this other thing, but this is making all those other problems worse. And we can address this if you want to, but really, I think giving the patient sort of that agency, that the ability to make that choice. And I think I've only had one time where I've, had that conversation that Deepa was just describing and had people say, hard stop, no way we're doing, medications for opioid use disorder. And
You're batting way better than I do.
Yeah, me too, Chris.
Well,
Me too.
yeah, no, in adults, it's happened all the time. Sure.
Right.
But I think that, but even, and I followed up with that family and they were still really struggling like months later. It was kind of like this kid was on house arrest, trying to keep him safe. And so I think just leaving the door open then, if they're not willing to have that discussion right now, or they're not willing, it's like anything, right? Sometimes you have to come back to it 2 or 3 times and kind of move them through the stages of readiness to change. And you have to count on your colleagues to do that.
Is it you're having that conversation, they're interested in treatment. We get a lot of, 16, 17-year-olds in our EDs. Both are sort of community sites, not really at our academic site because we have a pediatric ED there, but at our community sites, we get a lot of 16, 17-year-olds who may come without a parent. And so when you're in that situation, how do you think about things like consent and notification? Like, do I need to, call the parents and make sure they're okay with what I'm about to do? Because, this isn't really just like, antibiotics for like a UTI. On the other hand, it is a controlled substance. On the other hand, it's a little bit different than other things. And so how do you guys approach that?
I mean, I think that's going to vary depending on where you're practicing, right? The state that you're practicing in. So in Washington, we can treat kids confidentially at age 13 and over, and so that's what our protocol reflects. If the adolescent doesn't want their parents to be involved in this decision, I mean, I lean on them a little bit to say, hey, look, like this is kind of a big deal. Your parents are going to probably find out at some point because they're going to get a bill or the pharmacy is going to call or whatever. I am really happy to help you have that conversation and help sort of guide that conversation with your parents to make sure that they are on board because, they're going to need to help you out at some point. And I think almost every kid, I think every kid has basically consented to that so far. But yeah, I think if they were really, kind of committed to the idea of leaving their parents out of it, I would still be willing to treat and prescribe without parental consent because I think, this is a life-threatening illness and the law kind of gives me that latitude where I practice.
I practice in a state where we do have to receive parent consent to prescribe medications, regardless of what they are, really. Um, so I I always think it's best to involve parents or another trusted adult. In my state, it does have to be a legal guardian or parent involved to provide consent for medications to be prescribed. I just explain that to the kids. Some kids decline medications, but I do also, in my heart, think about their risk of death and whether ethically I should withhold their confidentiality or not. Unfortunately, because we are living in the age of fentanyl, it is really risky business to not inform another adult because it's almost like Russian roulette right now with kids and fentanyl. So I have not had a case where I've withheld this information or kept confidential from a parent or guardian. And that is also, again, guided by my state's laws.
Yeah, and I think that's worthwhile for our listeners to, just ask your medical director, like, what do we have to do when we have to do it? But my guess is that there's probably more latitude broadly in many places across this country than many people would think. I think we tend to bias ourselves towards thinking we're not allowed to do things when often we are allowed to do things. And so you got to figure out what you can do in your practice setting, in your state. And if there's an opportunity to treat more people, take advantage of it. This has been great. I have learned a lot today. I now know that there's probably a lot more teenagers out there with opioid use disorder that are getting missed because we're not screening, we're not thinking about it, sort of the tip of our mind in the same way that we might amongst adults. I'm feeling really comfortable about the fact that the approach to treatment is pretty similar to what I do feel comfortable with in adults. I'm going to use CAL scores. I like the idea of 4 and 4. That's a really easy thing to get my head around. Unlike other pediatric dosing, I'm not thinking about mgs per kg and did we get the weight in the computer first and things like that. So that's actually very reassuring. And I think you guys have reassured me as well in terms of thinking about like how parents are going to react. One thing we do on the episode, every episode, is I always give our guests a chance to have your own soapbox. I know you guys are experts in this space. You are helping, EDs around the country, physicians around the country treat opioid use disorder in teenagers. What's one last piece of wisdom or parting thought you'd like to give all of our listeners for the Emergency Quality Network?
Go ahead, Deepa.
Oh, well, I'm a pediatrician and I respect EM physicians so much, and you do hard things. This is not one of those hard things. I'm amazed at your technical skill and your medical skill. I really want to reach out and say, I'm a pediatrician. I do it. I have all the confidence you can do it. This is not the hardest thing probably that you face in your job.
Yeah, I would agree. So in fact, to me, this is like the nursemaid's elbow, right? Where people see a nursemaid's elbow check in and everybody's trying to sign up for that patient because it's your big hero moment, right? Where you can fix them and everybody loves you. And this is the same thing, right? It is so easy and it makes such a massive impact on people's quality of life. And I think that, across the country, the numbers always look worse and it's scarier and more awful all the time. And we're always waiting for someone to come along and do something. But I think the people that are listening to this podcast, they are the people that need to do the thing, right? We're never going to have enough, Deepas out there to treat all of these kids. There's never going to be enough me's out there to treat all these kids. Everybody can be doing this, and everybody really should be doing this because you can save a life and really turn a life around.
That is a wonderful call to action and a morsel of feasibility. I like it all. So thank you both for joining. Hope to have you back on in the future. Keep doing the great work that you're doing and helping us lead this forward.
All right, thank you.
Thank you.